Good morning, everyone from Accriva-Diagnostics, and welcome. To our viewers and friends around the globe, good afternoon or good evening. We are so glad you can join us. Before we begin, allow me to introduce myself. My name is Hassan Tamadani, and I am the product manager for the Hemochron product family. And on behalf of Accriva-Diagnostics, we are excited to host this webinar presented by our distinguished guest presenter, Mary Jo Grodsky, the point-of-care coordinator for Orlando Regional Medical Center in Orlando, Florida. She is an active member in the point-of-care community, participating as a panel member, mentor, and presenter with various committees associated with the American Association of Clinical Chemistry and the Florida Society of Clinical Laboratory Scientists. Today, Mary Jo will share how she carried out Orlando Regional's conversion of over 30 Hemochron responses to the Signature Elite cuvette-based system. Without any further ado, I would like to hand it off to Mary Jo. Mary Jo, good morning.
Good morning, everyone, and thank you to you all for joining us today. I am very excited to be presenting to all of our guests. Today's webinar is focused on how my team and I were able to convert 37 of our tube-based Hemochron responses to the cuvette-based Hemochron Signature Elite. I have been sponsored by Accriva-Diagnostics today to present this webinar. I currently have no consulting relationships with any other vendor, and all the information provided today is a reflection of my experience at Orlando Regional Medical Center, including the procedures, evaluations, opinions, and patient management suggestions. Our objectives today: first, we will describe the challenges we anticipated we would encounter during the transition at Orlando Health. I will review Orlando Health's transition plan, our request for information process, our new method instrument evaluation process, our training and competency program, and our implementation plan. And finally, in summary, I will share what we learned during the transition so that you will be prepared for your future transition. So who am I? Well, I've been a medical laboratory scientist for over 35 years. In June of 2016, I celebrated my 30-year anniversary at Orlando Regional Medical Center, where I have worked in the general laboratory, in the chemistry lab, served as a senior tech and student mentor. Over the years, I developed an expertise in quality control, quality management, and regulatory issues. I'm viewed in the organization as the expert resource. I have been actively involved in the Orlando Health point-of-care testing program since 2001. I serve as a network co-chair for the Central Florida Point-of-Care Coordinators Network. And I am an active participant in the American Association for Clinical Chemistry, including the Point-of-Care Testing Forum Committee, and have presented for the forum. Orlando Health highlights. Who are we and what makes us a healthcare leader? We have 8 leading community hospitals, 3 nationally recognized specialty hospitals, and 1 world-class cancer center. Orlando Regional Medical Center is the flagship medical center. We are a teaching hospital and a level 1 trauma center. We are the trauma center that provided the first response to the Pulse nightclub tragedy in Orlando. We have over 14,000 team members and 2,200 physicians, and a very large medical education program. Who do we serve at Orlando Health? We have 2,200 hospital beds where we provide care for 2 million residents and thousands of international patients. And you can see on the graph the diverse patient populations we serve. There are many challenges to consider when transitioning ACT methods. As we plan to transition our method, we realized we would need to prepare for each of these challenges. First, we had to know and understand each method so we could educate our clinicians and operators and make the right decision on our method instrument choice. We had to know and understand the various patient populations where we use ACT to monitor heparin so we can advise on the appropriate cuvette choices. We needed to know and develop relationships with our key players. We had to understand the process and studies to verify the ACT test as required by our regulatory agencies. We had to develop a plan to manage inventory on approximately 15 units across 3 hospitals. And finally, we would develop a plan to implement and go live with our new ACT method across the 3 hospitals. The transition from the response to the elite was a large and challenging project. And whenever I am challenged with a difficult question or a situation, I always go back to the patient. I ask myself, is my patient safe? I refer to the 5 rights of patient safety. Have I selected the right method for my patient? Am I using the right device for my patient? Is the right operator performing the test? Did the operator receive the right training? And is the right documentation available to my clinician? I might also need to consider right supplies, right budget, right outcomes. There are many, many rights, but always patient safety first. To accomplish the transition to the elite, we needed a project plan. We divided the project into 5 phases. First, we would request and review information from both our current vendor and from a competitive vendor. Next, we would need to justify the budget to replace the 37 responses. Once we selected and purchased the new instruments, we would perform method and instrument verification procedures. We would need to train and assess competency of approximately 500 operators. And finally, we needed a plan to implement 37 elites across the 3 hospitals. The first phase of the project was to request information. We started by selecting the evaluation team. In the team, we included key players. This inclusion of key players was a significant factor in our success. The key players we included were perfusionists, registered nurses, EP techs, cath lab techs, CRNAs, and physicians, of course. The team was engaged and they were excited for this transition. We had a long-standing and mutual respect. We genuinely enjoyed working with each other, as you can see, as indicated by the love note on the right. If you can, include a clinical champion on your evaluation team. Our clinical champion was the entire perfusion team. This team made a huge contribution to our success. The perfusion team had experience with the 3 ACT options we were reviewing, the Hemochron Response, the Hemochron Signature Elite, and the iStat. The Hemochron Signature Elite was by far perfusion's first choice. They needed the precision and accuracy that cuvette technology would bring. They wanted the rapid count technology with the ACT+, and they were excited to finally have an internal, truly automated EQC process. The perfusionist team spoke with the clinical teams. They helped bridge the sessions between each of the clinical teams. We requested and evaluated information from Accriva, our current vendor. We compared the response tube technology to the elite cuvette technology. On the response, the clot detection method was mechanical magnetic. On the signature elite, we would have mechanical optical, which would provide improved precision and accuracy. The EQC process on the response was external and manual. On the elite, it was internal and fully automated. The sample size on the response was 2 mL. On the elite, 1 to 2 drops. This was important to our neo and pediatric populations and for blood conservation in our adult hospitals. The time to result on the response with an example target time of 480 seconds is approximately 8 minutes, while on the signature elite with an example target time of 420 seconds is 4.5 minutes. On the response, the lockout feature was challenging, while on the elite it was very easy to enable. The barcode scanner on the response was a separate accessory. We never even used it. On the signature elite, it was internal, and we anticipated this would improve our operator ID, patient ID, and barcode and lot number tracking. Next, we requested information from a competitive vendor. We compared the signature elite to the iStat. On the Signature Elite, the EQC process was fully automated and internal. On the iStat, while there was an internal EQC process, there was also a periodic external EQC process. The time to result on the Elite, with an example target time of 420 seconds, was 4.5 minutes. On the iStat, example target time of 480 seconds, approximately 8 minutes. The room temperature shelf life on the Signature Elite was 12 weeks. We anticipated this to have a huge positive effect on our inventory management. On the iStat, there was only a 2-week room temperature shelf life. We already had challenging managing our other 2-week iStat cartridges, glucose and creatinine. The coagulation test menu on the Elite was ACT+, ACT low range, APTT, and PT. On the iStat, we would have ACT+, and PT-INR that was limited to Coumadin monitoring. The clot detection method on the Elite was a mechanical optical method. It was a true endpoint clot. On the iStat, it was electrochemical. It was not a true endpoint clot. The true endpoint clot was very important to our physicians and our perfusionists. Now, before I discuss this slide, I would just like to say I am not an expert in coagulation, but you cannot discuss a coagulation test without at least one coag cascade slide. Our physicians and perfusionists were particularly interested in an endpoint clot detection method because it evaluated the common pathway of the coagulation cascade, and the results reflected the formation of a fibrin clot. This is an important factor so we could ensure we had an instrument that was sensitive to fibrin deficiencies. Now that our evaluation was complete and the team had selected the Elite to replace the responses, we had to justify to the finance team the expense to purchase the 37 Elites. We shared with finance what we considered as costs associated with the response. Our responses were 7 years old. They were at end of life. There was an expense to repair these devices. The tubes on the response were bulk packaging. Operators like to break up these bulk packaging, put the tubes in every drawer and nook and cranny imaginable, often leading to tubes expiring and waste. The response was technique dependent. This affected precision and accuracy, which resulted in repeat testing. We had connectivity challenges with our data management system. This led to issues with documentation of results and reconciliation of billing. The EQC accessories were also aging and needed to be replaced. This was an additional expense. Then we shared with finance what the team saw as benefits to the Elite. With the Signature Elite, we would have improved precision with cuvette technology. This would result in better patient care and less repeat testing. We would have a true internal, fully automated EQC process with no additional accessories. This was a huge end-user satisfier. We would have rapid count technology. This would provide faster treatment decisions, another end-user satisfier. We would gain more flexibility as we transition to our new data management system with RALS and the Elite. This would give us improved regulatory compliance, electronic recording, and billing. We would have better heparin therapy management, which would result in better patient care. Our plan to replace the 37 responses was divided into 3 phases as money became available. Our most immediate need was in the CVOR. So in early 2014, we were able to purchase 2 Signature Elites. We verified these with ACT+. Then we had money to purchase an additional 3 Elites, which we verified for ACT+. So now that we had 5 Elites verified for ACT+, we were able to implement ACT+ in our CVOR rooms for patients on pump. In late 2014, money became available to purchase an additional 15 Signature Elites. We began verifying these for ACT low range in the general surgery population. By early 2015, we were able to purchase the remaining 17 Signature Elites. We verified ACT low range in the other patient populations, cath lab, EP lab, cardiology units, and angio. Now that we have 32 elites verified for ACT low range, we could implement ACT low range across the 3 hospitals outside of the OR. I will now review our method verification process. On the right is a checklist we use at Orlando Health to guide us through this process. Number 1, follow your regulatory agency policies. At Orlando Health, we are accredited by the College of American Pathologists, and we must also comply with federal and state regulations. Number 2, use your in-house processes. You don't need to reinvent the wheel. 3, include all patient populations. You may need to divide and conquer to accomplish this challenge. 4, include your end users, the operators and physicians. But to minimize variability, allow the lab technicians to oversee this process. Including the end user in the verification process will contribute enormously to a successful transition, as the clinical team will have the time to get used to the differences in the 2 methods and the possibility of a change in target range. I will also share that although our perfusionists were competent response and elite operators, it was difficult to dose both instruments simultaneously during the comparison and remain focused on patient care. So my lab team assisted on each case with performing patient comparisons along with our operators. It was truly a team effort. And finally, ask your vendor for help. Accriva was supportive all the way. We performed method verification studies on each cuvette type, ACT plus and ACT low range, on our 1 primary analyzer only. For analytical accuracy, we collected greater than 50 method comparison data points across the reportable range. For precision, we performed low and high QC for 10 days and calculated the SD and CV. Although not required on clot-based testing, we did perform the heparin response test. We verified the normal range with our method comparison study, and we referenced the accriva package insert for each cuvette type for analytical interferences. And again, we performed the method verification studies on our primary analyzer only. For each additional 36 instruments, we perform the following modified instrument verification study for each cuvette type, as allowed by our accrediting agency. We performed accuracy study on 3 samples over the reportable range. We verified precision by running 2 levels, 5 replicates, and calculated the SD and CV. And again, although not required, we did perform the heparin response curve with the help of our rep. The method precision study on the ACT plus cuvette on our primary analyzer demonstrated CV of 6.3% for our normal QC and 1.9% for our abnormal QC. I have never seen a 1.9% CV on a response ACT test for precision. This was an early indicator of the improved precision we could anticipate with the elite. Although it's an optional study, we decided to perform a heparin response test for the signature elite because we wanted to assure the confidence we had in the instrument to the rest of the team that may have been skeptical. Although the heparin and clotting is not a linear relationship, our response chart demonstrated the increase in clotting times as we administered larger concentrations of heparin. This slide demonstrates the method comparison target range study that can be found in the ACT Plus package insert. We shared this early in the process so the clinical team was aware of the possibility of a target range change. I want to emphasize that the ACT Plus results with the signature elite may yield an average difference approximately 10 to 15% lower than the gold standard C-Lite ACT assay on the Hemochron Response. For example, the therapeutic range of 480 seconds on the Hemochron Response may be equivalent to a therapeutic range of 420 C-Lite equivalent seconds on the signature elite. As you can see in the graph provided in the package insert for the ACT Plus, as the therapeutic range increases, there's less of a linear correlation. This doesn't mean that one is better than the other, It just means that each institution needs to learn how each instrument performs differently. As you will learn later during the webinar at Orlando Health, we did not have to adjust our target times, but it is absolutely important that each institution establish its own therapeutic target range by performing their own studies. On the left is a snapshot of the tool we used to collect data during our ACT Plus method comparison study. We collected data from approximately 20 different CVOR cases, being sure to include each of the CVOR surgeons. We included data points throughout the procedure, including the baseline, heparin monitoring during the procedure, and protamine reversals at the end of the procedure to ensure we covered the reportable range. This graph represents the result of our comparison study. As explained earlier, we anticipated the possibility of some negative bias or a nonlinear comparison, so we were not alarmed. The best advice I have is educate your clinical team early in the process to the possibility of change, and always do your own evaluation and establish your own target times. At Orlando Health, we had an established target time of 450 seconds with an established target range of 400 to 480 seconds, depending on procedure and physician in the CVOR. The average difference for the study across 97 samples was a negative 28 seconds, or 7%. The CVOR surgeons and the lab director reviewed and discussed this data and did not think this warranted a change in target times for CVOR patients on pump. We also performed method verification studies on the ACT low-range cuvette. We performed method comparison in the appropriate patient populations in the cath lab, angio, cardiology recovery units, and EP lab. We collected 93 data points across the reportable range. The average difference for the study was up to a negative 12 seconds. Again, the medical staff and lab director reviewed the data and discussed it and did not think this warranted a change in target times. As we completed verification on each cuvette, ACT Plus and ACT low range, on the 37 elites, we could move on to the next phase, training and competency assessment of our 500 operators. We had included our operators in all phases. They participated in the request for information, in the evaluation of the information and selection of the instrument, and in the verification of the method and instruments. We had a mature point-of-care testing program. We had experienced super users. We had a learning management system that could document our training and competency, and we had a well-developed hands-on training program. And ACT was not a new test for our operators. They were getting a new instrument, and the learning curve was for the instrument technology. I would compare this to when I get a new smartphone. I've been using a smartphone for several years now. Every so often I get a new one, I have to learn the new buttons and the new functions so I can operate it correctly. Our operators were engaged and excited for this transition. Although we covered intended use for each cuvette type, as indicated by this slide, during our verification study and training, as you will see when I review the post-implementation slide, we did need to review this on specific units after go live. And again, although the intended use for both the ACT Plus and ACT low range is clear from the training provided by Accriva and the package insert, it can at the start be confusing for some end users to choose the right test. Accriva has made an effort to make the cuvettes distinguishable by color-coding both the labels on the cuvettes and the packaging, but you must constantly be on top of your team so that they understand the differences. Now that our operators were trained, we were ready to implement. We implemented the ACT Plus in early 2014 in the CVOR. This was an easy implementation. There were no target time changes, and we were supported by our clinical champions, the perfusion team. Quite honestly, the lab team could not move fast enough to purchase the elites, get the ACT Plus verified, document training and competency so the perfusionists could begin using the ACT Plus on their patients. In early 2015, we implemented the ACT low range, 32 devices, across 3 hospitals. For the scope, it was actually a fairly easy implementation. I would credit this to the fact that we included key players in all units from the beginning. And again, having no target time changes simplified the process. Post-implementation. How successful was our rollout? On day 1 for the ACT Plus in early 2014, we had no issues in the CVOR. Again, we can credit the perfusion team. For the ACT low range in July of 2016 on day 1, we did have one operator who chose to run the signature elite and the response side by side because they were nervous. Fortunately, we had an astute learning specialist who stepped in and guided the operator. This operator is now a huge fan of the signature elite. Week 3 for the ACT low range implementation. In the EP lab, although we had gone live with the ACT low range, we learned some position targets were greater than 400 seconds. So we needed to stop both the ACT Plus and the ACT low range in the EP labs and ensure that the operators knew how to make the choice for the right cuvette at the beginning of the case and continue to use that cuvette throughout the case. Month 15, our vascular OR cases were increasing. We had ACT Plus cuvettes in the surgery. Target ranges verified by physician and procedure, and we learned that some of them were less than 400. So we had to go back and stock both the ACT Plus and the ACT low range cuvettes, and again review with the operators that they knew how to select the correct cuvette from the beginning of the case. Year 2 and beyond, Orlando Health has been successfully managing patient care with the signature elite. We've actually expanded use to include the PT-INR for our stroke alert and our special communicable disease unit. Some advice post-implementation: understand the differences between ACT Plus and ACT low range for each of your patient populations, as they are not the same, and ensure your operators also understand. Constantly monitor and follow up with each department. Don't be afraid of change. You might learn that your end users are ready for a more precise and more accurate test. And little bumps can be overcome. Just divide and conquer. In summary, what did we learn and what I hope you learned today? Number 1, there will be challenges during this transition. Understand them and plan for them. Do your homework. Request information for your instrument selection. Understand the differences in methods and absolutely include your key players, as this is imperative to a successful transition. Plan for the budget. For your method verification, include all patient populations. You may need to divide and conquer to accomplish this task. Include your end users, your operators, and your physicians, but lab techs should oversee to minimize variability. And ask for help from your vendor rep. If allowed by your regulatory agency, perform a full method verification on your primary instrument and a modified instrument verification on each additional instrument. If you've included your operators in all phases, your training and competency should be smooth. Our target range didn't change. This did provide an easier implementation for us. But don't be afraid of a target range change. Reach out to your informatics and pharmacy team to adjust protocols and order sets if required. And always, patient safety first. Before I hand it off to SAS, I'd like to say thank you to everyone again for joining us today. And I hope the material presented today will help guide hospitals, fellow point-of-care coordinators, and other healthcare professionals to prepare for future implementation. Thank you, SAS.
Thank you, Mary Jo. That was a great presentation with a lot of material for our viewers to take away. You and your team at Orlando Regional certainly did a terrific job with converting over 30 instruments. What I appreciated most about your experience was how you made sure it was a group effort by including all the key players getting them engaged and excited to understand the differences in results and setting the expectations during the post-implementation. Now I'd like to start taking questions from our audience. You should have a little chat box on your screen. Please click in the entry field to type and submit your questions. As the questions funnel through to me, I will read them out and Mary Jo will answer accordingly. Okay, so let's get started. All right, so the first question we have, Mary Jo, is, so someone wants to know is, in a surgery case, they want to know what your recommendation is for if you're running an ACTLR or ACT Plus before the surgery.
You always need to know what the target range is for the case, for the procedure, and you use the same cuvette throughout the case. So okay. Even though, I know it's confusing, even though low range is for 200 to 400 and your baseline will be lower than that, you're still going to do the baseline on the cuvette choice you're making for the target range. So you don't change cuvette types during the case. This is a difficult concept for the team where we have both cuvette types stocked to get through. This took a couple tries.
So the second question then is, one person was asking if the LQC validation on the ACTLR was a challenge for you.
If the which validation, I'm sorry?
The LQC validation, lower liquid quality control validation on ACTLR, if it was a challenge.
No, it wasn't. It was very similar to the ACT Plus.
Okay.
Now, I will tell you this. Running liquid QC on the elite is a new skill set. You've got to give operators time to develop that skill, but once they get good at it, it's fine. And so they really need good training by the lab team.
All right, the next question we have, Mary Jo, is, was there any confusion in regards to the nonlinear relationship between the response and the signature lead ACTs at first? And if so, how did you try to resolve the confusion?
I think we were fortunate because we had perfusionists involved who had experience. They were able to help us with the clinical teams. And because we actually just brought that up from the get-go, we didn't try to hide it. We were very upfront with it. So there were no surprises. And they were fine.
The next question is, Orlando Regional didn't have to change its therapeutic target time. Do you suspect that this is rare or common practice among other hospital departments?
I don't know the exact numbers, but for the other POCCs I know, it's neither rare or uncommon. It's somewhere in the middle there. So it's really a case by case. Okay.
There's also a follow-up question to that asking, what advice did you have for anyone who has to change their therapeutic target time?
Number one, acknowledge that possibility from the get-go. Number two, once you know that there will be a range change, communicate, particularly to your physician team. And number three, reach out to your informatics team and your pharmacy team. These are the people who can make the changes happen on protocols and order sets as required.
Okay. So one of the slides showed the heparin concentration range applicable for each type of ACT cuvette on the signature lead. Can the question is, can the ACT Plus and LR be used interchangeably in the overlapping concentration ranges?
Whatever cuvette you choose, based on what's your dose, that's what you want to stick with. Now, what we learned in the EP lab, because we had some physicians whose target range was right around 400, they did not like to see just greater than 400. So that's why we had to add the ACT Plus. I think that was the question. I'm not quite sure.
So they were asking if there's because there's no ranges between the Plus and LR, and some of those ranges sort of overlap, if you can use them interchangeably within the same procedure. So looking at sort of sensitivity.
Never. No, never within the same procedure. Choose your cuvette and stick with it.
Okay.
That is what ACRIVA recommends, and then we have found, because we had some operators doing that, and it was causing confusion. Once we got them to choose the correct cuvette, particularly in those couple of units where we had ranges that overlapped right around the 400, where we had to stock both. Choose the right cuvette and stick with it.
The next question is, do you use the ACT-LR on the signature lead for monitoring ECMO patients in both pediatric and adult patients?
We absolutely use it in our pediatric population. We did a couple of adult trials with the ECMO, but I haven't heard too many more ECMOs in about the last year, so I'm not quite sure where we are with the adult ECMO program.
Okay.
But we did use the ACT low range.
All right, the next question is, who orders inventory for all the testing departments? Either the testing department or the POCC?
So at Orlando Health, we made a decision that the lab would order the inventory. We had a pretty good idea before we went live what the PAR levels were with our old response. And so once a month, we go in and we touch base with the unit. We provide them with their PAR level of cuvettes at room temperature. It also provides a good face time. This took us 1 or 2 months to kind of, even out, but it's been very smooth since. And what we have found, we like to maintain inventory of the refrigerated cuvettes, and then we let the units maintain inventory of the room temperature cuvettes. And that seems to work very well for us.
Okay, the next question is, what do you recommend as an appropriate sample size for method verification?
I would say at least 50, because you really need to get into multiple procedures and you need to cover from baseline to reversal, particularly for the ACT+. So I'm not sure how you would do that without at least 50 data points. We had closer to 100. It took us 100 points to really feel confident with the data points.
Okay. There's a question coming in asking if you could explain a little bit the difference in time seconds between the elite, signature elite, and the Hemochron Response.
So with the Hemochron Response, those are real-time seconds. On the signature elite, because the cuvette is optimized, there's something called C-like seconds. It's a little bit magical to me. I would have to reach out to the technical experts at ACRIVA. But so it's an accelerated time, and that's how that's why you get that shorter run time. But it really is a few minutes shorter, and I've run them side by side, and it is, and the team really appreciates that.
Next question, Mary Jo, is how long did it take to accomplish the 100 validation points?
In the CVOR, it did take us a bit of time, probably I want to say a couple of months at least. And part of that was early on. We thought because perfusion were very competent, they could do it without help. But what we learned, it was just too difficult logistically to be dosing both devices and maintain patient care. So then we had to kind of go, we learned a lot on our first couple of cases, and we had to kind of backpack and then make sure the lab tech was up there. So learn from
Mary Jo, we're going to take a couple more. We're going to take a couple more questions, and then what we'll ask is that we'll try to respond to these questions later with a document posted online. The next question we have is, well, where did it go? Okay, so did you have to adjust target time when switching from the response to signature lead in the for cath lab procedures?
We did not. We used the ACT-LR in the cath lab, and we did not have to change target times.
Okay. And we'll take one more. Assuming you review target ranges on a regular basis post-implementation, have you ever had to modify your target range or consider modifying your target range due to a change in patient population?
We had a little bit of discussion with our vascular surgeons about that, and we thought we might, but when we really explained to them the differences in the cuvettes, they realized they were choosing the wrong cuvette for their cases that had a lower target time. By transitioning to the ACT-LR, it solved the problem, so we did not have to adjust target times.
Okay, Mary Jo. Well, that's all the time we have for today. Thank you so much. Before we end our session, I just want to let the audience know that today's webinar has been recorded for future playback. Be on the lookout for an email with information to access the video, and we will respond to the additional questions we didn't have time for today. I want to thank everyone for joining us, and a big warm thank you to Mary Jo Grodsky for being our guest presenter. Have a great week, everyone. Thank you so much, and goodbye.